So imagine a skin condition that is incredibly common and just intensely uncomfortable, but completely treatable. Like you manage it, you live with it.
Right, it just becomes part of your routine.
Exactly. Until suddenly it masks something far more dangerous. Welcome to today's deep dive. We're sorting through a massive stack of sources today.
Yeah, we've got medical guidelines from the British Association of Dermatologists, pathology reports from Frontiers in Oncology.
Some really heavy clinical pathways from the Mayo Clinic and the NHS too. And the mission for you listening today is to solve a very specific, really high-stakes medical mystery.
It really is a mystery.
It is. How do clinicians actually differentiate lichen sclerosus, which we'll just call LS for short today, from a highly aggressive precancerous condition known as vulvar intraepithelial neoplasia, or VIN?
And, the stakes here really couldn't be higher. I mean, we are talking about the literal difference between prescribing a topical steroid and, well, ordering a surgical excision.
Right. And because these conditions share heavily overlapping symptoms on, frankly, the most sensitive parts of the human body, the diagnostic waters are just incredibly murky.
Oh, absolutely. They mimic each other constantly.
So to understand how LS essentially acts as camouflage for this precancerous condition, we really need to establish what that baseline camouflage looks like. Most of you probably know that lichen sclerosus is an autoimmune-driven inflammatory disorder.
Yeah, and we see it predominantly in postmenopausal women, though. The pediatric cases are just as important to track.
Yeah, the kids dealing with it is heartbreaking. But the part that really fascinates me is the mechanics of the friendly fire. The immune system isn't just randomly attacking, right? It's targeting very specific structural proteins.
Exactly. The current literature heavily points toward autoantibodies targeting something called extracellular matrix protein 1, or ECM1.
ECM1, and that's basically the glue, right?
Yeah. Yeah, that protein is essentially the glue holding the dermis together and regulating blood vessel formation. So when the immune system attacks ECM1, you get this massive inflammatory cascade.
It just ruins the local environment.
It really does. The tissue loses its elasticity, the blood vessels become super fragile,
Yes.
and the skin undergoes these profound architectural changes.
Which perfectly explains the visual presentation, because the sources describe the skin turning this ivory white color and taking on a texture like crinkled cigarette paper.
A lot of wax paper.
Wax paper, right. It's essentially the visible fallout of that structural glue just being destroyed. And you often see this forming a figure-of-8 pattern encircling both the vulva and the perianal area.
But there's a really crucial boundary line here that the inflammation just refuses to cross.
Oh, right, the internal cutoff.
Yeah, it causes severe anatomical changes, shrinking or resorption of the labia minora, burying of the clitoris, but it stops dead at the vaginal mucosa.
And why is that? Why doesn't it go internal?
Well, that boundary is a vital clinical clue. LS exclusively attacks keratinized epithelium. The internal vaginal mucosa is non-keratinized.
Got it. So it's a different tissue type entirely.
Exactly. It's a completely different cellular landscape, so the autoantibodies just don't have the same targets there. If a clinician sees internal mucosal involvement, they instantly need to pivot their thinking away from LS.
Towards something else entirely, like lichen planus or something.
Right, exactly.
Okay, so we have this chronic, painful breakdown of keratinized skin. And if it's just friendly fire, you might think the worst of it is the impact on quality of life. The pain, the tearing, the sexual dysfunction.
Which is severe on its own, honestly.
It is. It's awful.
Yeah.
But the medical guidelines emphasize a much darker consequence. For a small subset of patients, usually under 5%, this exact inflammatory landscape becomes the breeding ground for squamous cell carcinoma.
Yeah, the cancer risk. The chronic inflammation essentially creates a state of constant tissue injury and repair. Your cells are turning over at an accelerated rate just to try to patch the damage.
Like constantly rebuilding a wall while someone is knocking it down.
Perfect analogy.
Yeah.
And anytime you force cells into overdrive like that, you exponentially increase the risk of a DNA replication error. And that less than 5% risk is exactly where our second condition enters the picture.
Right. Vulvar intraepithelial neoplasia, or VIN.
The precancerous stage, yes.
But the pathology reports make it very clear that VIN isn't just a monolith. There are two completely different pathways that lead to this neoplasia, and they behave like entirely different diseases.
Oh, totally different personality.
Yeah. Let's look at the first pathway, usual type VIN, or UVIN. We also see it referred to as HSIL in some of the literature. This pathway accounts for 95% of cases and is driven entirely by high-risk human papillomavirus.
Specifically HPV types 16 and 18.
Right.
And the demographic and the mechanism here are completely separate from LS. UVIN typically strikes younger women. The virus infiltrates the basal cells of the epithelium and starts expressing these oncoproteins, specifically E6 and E7.
And what do those proteins actually do?
Well, these viral proteins actively dismantle the cell's natural tumor suppressors. They basically hijack the cell cycle to replicate wildly.
So it's an inside job, and there's a fascinating link to smoking here too, which I didn't realize before reading the sources. Smoking doesn't just damage the lungs. The nicotine and cotinine actually concentrate in the cervical and vulvar tissues.
Yeah, it's a huge risk factor.
It literally paralyzes the local Langerhans cells, which are, the immune cells that are supposed to be fighting off the HPV in the first place.
The immune system essentially gets chemically handcuffed by the smoking, allowing the HPV to just run rampant. Clinically, this presents as multifocal lesions.
Meaning they pop up everywhere.
Yeah, in multiple distinct spots.
Yeah.
They often look really warty or basiloid, raised, and heavily pigmented.
Right, so it's the loud party crasher. It makes a mess, it's obvious, and you can see it happening across the tissue.
Exactly.
But UVIN takes a relatively long time to progress to invasive cancer, right? Sometimes 6 to 7 years. And occasionally the immune system actually rallies and clears it on its own.
It does happen.
But it's the other 5% that we need to be deeply, deeply concerned about. Differentiated type VIN, or DVIN.
Yes, this is the quiet, highly lethal local.
Oh, that's a good way to put it.
Thanks. I mean, DVIN is entirely HPV independent. There's no viral party crasher here. Instead, DVIN arises directly out of that exhausted, chronically inflamed tissue of lichen sclerosus.
From the friendly fire we were talking about earlier.
Exactly. The oxidative stress from years of immune attacks finally causes a catastrophic mutation in the basal cells.
And the timeline for this one is terrifying. The sources show DVIN can progress to invasive squamous cell carcinoma in just 2 to 3 years.
It's incredibly fast.
But, I mean, if it's that fast and that aggressive, clinicians should be catching it immediately, right? Yet, the Frontiers in Oncology paper highlights this massive diagnostic trap. DVIN is constantly being misdiagnosed as just a bad flare-up of the patient's existing lichen sclerosus.
It really comes down to how perfectly DVIN mimics the surrounding damage.
The camouflage.
The camouflage, exactly. To the naked eye, it rarely looks like those raised, warty clusters we see with UVIN. It typically presents as a solitary, unifocal lesion. It might just be a thickened plaque, a slight ulceration, or an area of hyperkeratosis.
Which is exactly what severe lichen sclerosus looks like anyway. The skin is already thickened, it's already ulcerated from scratching. The precancer just blends right into the background noise.
It's totally hidden.
So the clinician does the right thing, right? They take a biopsy to look under the microscope. But the pathologists are missing it there, too. How does a pathologist miss it?
Well, because standard H&E staining was historically calibrated to catch the viral type, the UVIN.
Oh, interesting.
Yeah, in a UVIN sample, the viral chaos causes what we call full-thickness atypia. The abnormal immature cells take up the entire vertical space of the epithelium.
From top to bottom.
Right. You look through the microscope, and the tissue looks completely disorganized, from the basement membrane all the way to the top surface. It's basically impossible to miss.
But DVIN doesn't do that.
No, it doesn't.
The cellular behavior is completely different. The dangerous mutated cells are hiding exclusively in the basal layer, which is the very bottom of the epithelium.
The basement.
And the cells that get pushed to the surface actually retain their ability to differentiate. So the surface maturation is completely preserved.
It's an incredible biological deception, honestly. The basal cells are severely mutated, but they still possess enough of their original programming to flatten out and produce keratin as they migrate upward.
They act normal.
They act completely normal. So a pathologist looking at a routine stain sees a perfectly normal, mature layer of surface cells, and they assume the whole tissue is benign.
I mean, it's like looking at a seemingly healthy lawn. Like with UVIN, the toxic weeds have grown all the way from the dirt to the top of the grass. Anyone can see the lawn is ruined.
That's a great visual.
Thanks. But with DVIN, the surface grass looks perfectly fine and green. The toxic weeds are entirely hidden deep down at the root level, just mutating quietly.
And that preserved surface maturation is why pathology reports frequently underdiagnose DVN as just, quote, squamous cell hyperplasia with chronic inflammation.
Oh, so they just blame the LS.
Exactly.
Mm.
They attribute the basal cell activity to the underlying lichen sclerosus trying to repair itself, totally missing the microinvasive lesion forming underneath.
Wow.
The patient in the Frontiers case study experienced exactly this. She was told she just had a benign thickening, and it wasn't until she developed lymph node metastasis that they went back, reevaluated the original slides, and found the hidden DVN.
That is a nightmare scenario for any patient managing LS. So
Totes.
if the visual overlap is that deceptive and routine microscopy is structurally biased against seeing it, how do we solve the puzzle? How does a clinician actually differentiate your lichen sclerosus from a developing DVN?
The defense basically requires two things: intense clinical suspicion regarding treatment resistance and molecular biomarkers in the lab.
Okay, let's start with the clinical suspicion.
Clinically, lichen sclerosus, despite being chronic, is actually highly responsive to ultrapotent topical corticosteroids. The gold standard is clobetasol propionate. When applied correctly, the inflammation subsides and the tissue softens.
So the red flag isn't just the presence of a plaque or an ulcer. It's a plaque or an ulcer that outright refuses to heal after a rigorous, supervised trial of clobetasol.
Exactly. The steroid suppresses the immune attack, but the lesion just remains.
Right. That isolated steroid resistance mandates a biopsy. And crucially, it has to be a punch biopsy, not a shave biopsy.
Yes, that distinction is massive.
Because of the lawn analogy, right. A shave biopsy only skims the mature, normal-looking surface cells.
Yeah, you just get grass.
But a punch biopsy punches a tiny, deep cylinder out of the tissue, ensuring the pathologist captures that basal layer where the mutant weeds are actually hiding.
Exactly, you have to get to the roots. And once that punch biopsy reaches the lab, the pathologist has to bypass the standard H&E stain and use immunohistochemistry.
And what does that mean, practically?
They apply chemical stains that bind to specific proteins within the cells. This is the ultimate tiebreaker. The two heavy hitters here are P16 and P53.
Okay, let's break down the mechanics of those markers, starting with P16. What is P16 doing?
So P16 is our surrogate marker for the HPV virus. In a healthy cell, the retinoblastoma protein, or RB, acts as a brake on cell division.
It stops the cell from growing too fast.
Right. But HPV uses its E7 oncoprotein to destroy that RB brake. The cell realizes its brake line has been cut, basically panics, and massively overproduces P16 to try and stop the runaway division.
Oh, so it's an emergency response?
Exactly. So if the pathologist applies the P16 stain and the tissue lights up in a solid block, what we call block positive, they immediately know they are dealing with VIN.
Because the virus is there. But since DVN is HPV independent, its RB pathway is fully intact. It won't light up for P16 at all. So the real smoking gun for DVN is P53. And P53's normal job is essentially the guardian of the genome. Like, if a cell's DNA gets damaged by all that chronic oxidative stress from the LS, P53 is supposed to trigger apoptosis.
Yeah, programmed cell death.
Right. It tells the mutated cell to self-destruct so it can't become cancer.
But in DVIN, the P53 gene itself is mutated. It completely loses its ability to trigger apoptosis.
So the guard is asleep.
Worse than asleep. The mutated P53 protein becomes incredibly stable. It stops breaking down and just accumulates, stacking up inside the nuclei of those basal cells.
Wow. It's literally like turning on a black light at a crime scene. To the naked eye, the room looks completely clean. But you apply that immunohistochemistry stain, and the accumulated broken P53 proteins glow right there in the basal layer.
It's undeniable.
The normal-looking surface cells just don't matter anymore because the molecular fingerprints are right there.
The black light reveals the exact molecular failure driving the disease, and the diagnostic toolkit is expanding too. The sources highlight some newer markers, specifically CK17 and SOX2.
Wait, why do we need those if we already have P53?
Well, because P53 mutations can sometimes result in a null pattern.
Meaning what?
Meaning the protein is completely deleted rather than accumulated, which can be really tricky for a pathologist to interpret.
Oh, I see. So it doesn't glow under the black light because it's just gone.
Exactly. So CK17 and SOX2 are essentially stem cell markers that should not be highly expressed in mature skin. But when a cell transforms into DVIN, it aberrantly turns these markers back on.
Oh, that's clever.
Yeah. So if a pathologist is looking at ambiguous P53 results, but they see high CK17 and SOX2 expression, they can confidently diagnose DVIN despite the deceptive surface morphology.
Okay, so the clinician spots the steroid resistance, the punch biopsy secures the basal layer, and the immunohistochemistry blacklight confirms the p53 mutation.
Hmm.
We have successfully differentiated LS from DVIN. So why is getting this differentiation right the absolute most critical juncture in this entire process for the patient?
Because the biological mechanisms of the treatments are completely entirely opposed to each other.
Right.
Treating lichen sclerosus is about suppressing an overactive immune system. The British Association of Dermatologists guidelines lay out a very specific tapering regimen.
Yeah, they say 30 grams of clobetasol over 3 months, using a half-gram fingertip unit, daily for a month, alternating days for a month, then twice a week.
And that transition to twice-a-week maintenance is paramount. You aren't just applying it when it itches. You apply it to keep the inflammatory cascade permanently shut down.
So it's preventative.
Yes. By stopping the tissue from constantly destroying and repairing itself, you drastically lower the risk of the basal cells making a DNA copy error. Rigorous steroid maintenance actively prevents the LS from mutating into DVIN.
That's huge.
It is. Alongside emollients to maintain the skin barrier, it's a lifelong management strategy.
But, and here's the twist, if that blacklight revealed DVIN, applying a steroid is biologically catastrophic, isn't it?
Absolutely catastrophic. I mean, think about what a steroid does. It suppresses the local immune system. If you have an actively mutating precancerous lesion, your immune system is the only thing keeping it in check.
So if you misdiagnose DVIN as an LS flare-up and hit it with clobetasol,
You are essentially disarming the body's security guards while the tumor is trying to break through the basement membrane.
wow. So what is the gold standard when DVIN is actually confirmed?
The surgical removal of the mutant tissue. Because DVN is so prone to rapid invasion, surgeons perform a wide local excision.
They just cut it all out.
Yeah, they cut out the lesion along with a significant margin of clinically normal-looking tissue surrounding it, just to ensure no mutated basal cells are left behind.
Got it.
In highly specific cases, laser ablation might be used to vaporize the epithelium, but the core principle remains the same. You must physically eradicate the corrupted cells.
The stakes of the diagnostic trap are incredibly visceral when you put it like that. A missed atypia in the basal layer doesn't just mean a delayed treatment. It means a patient is actively instructed to apply an immunosuppressant to an aggressive precancer.
Giving it a completely frictionless runway.
Yeah, a runway to become invasive squamous cell carcinoma within a couple of years.
Yeah.
The difference between finding that p53 mutation and missing it is the literal difference between a minor surgery today and a life-threatening oncology battle tomorrow.
It demands an incredible amount of humility and vigilance from both the clinician and the pathologist. You just cannot simply trust what the tissue looks like on the surface. You have to interrogate it on a molecular level.
Which brings up a really compelling thread from the pathology literature. We've talked about how subtle this basal atypia is, even with standard stains. The sources note that inter-observer agreement, meaning like the likelihood of 5 different expert pathologists looking at the exact same DVN slide and coming to the exact same conclusion.
It's historically quite low.
Right. Because human eyes, even highly trained ones, are naturally drawn to the preserved surface maturation. We are biologically wired to be fooled by the camouflage.
The visual bias is incredibly hard to overcome. If the top 80% of the tissue looks beautifully differentiated, the human brain naturally assumes the bottom 20% is just benign reactive change.
So where does that leave the future of dermatopathology? As we map more of these molecular markers, we're also seeing the rapid rise of artificial intelligence in diagnostics.
Oh, absolutely.
Like, machine learning algorithms are being trained on hundreds of thousands of digitized tissue slides right now. And an AI doesn't have a biological bias.
Yeah, it doesn't.
It doesn't get visually distracted by the healthy-looking grass on the surface, you know.
It just scans pixel by pixel. An algorithm trained to look specifically for basal disorganization and nuclear crowding won't suffer from diagnostic fatigue at the end of a long shift either.
That's a great point.
It could flag that single abnormal row of cells and basically force the pathologist to apply the p53 stain.
Could an AI become the ultimate failsafe? As we move away from purely visual pathology and deeper into molecular and computational analysis, maybe the next generation of diagnostics won't rely solely on human eyes fighting through the camouflage.
It's very possible.
Maybe the machine becomes the ultimate blacklight, catching the mutation before it ever has the chance to break through. Something for you to mull over as we wrap up this investigation into the microscopic battleground of lichen sclerosus. Thank you for joining us on this deep dive. Stay curious.